Greetings. The title of the lecture is Role of Endodontics After Dental Traumatic Injuries. The reference is Chapter 21 from the Science textbook. The intended learning outcomes of this lecture that the attendee, which is you will be able to know the clinical and radiographic features of dental traumatic injuries, how to execute examination, how to do diagnostic test, and what are the recommended procedure. In addition, to be aware of the possible complications and the consequences, what are the recommended treatment strategy, how long you should follow up the case, and what are the favorable and unfavorable outcomes. The presentation of dental traumatic injuries could vary from chipped enamel up to the effect of the face, and sometimes it extends to the skull. The most common recorded trauma is concussion, which is more than 30%. After that, it's the uncomplicated fracture of the crown. The examination of the affected tissue usually started by cleaning the face and the oral cavity with gauze and saline to see where is the laceration, what are the teeth missing. Also, the history need to be short and concise toward the trauma and any relevant medical condition. The most common used questions are where did the injury occur? How did it happen? When did it happen? Did you lose consciousness? And if there is any disturbance in the bite. The clinical examination usually will start from the exterior up to the inside the mouth, which is the face, the lip, the oral muscles, and examining the facial skeleton for any sign of fracture. And then we check the dental alveolar tissues, and we can do some pulp testing. The most common pulp test is the cold test, and some practices they have the laser Doppler machine, which can measure the presence of oxygenation inside the tooth. Radiographic examination, mainly pre-apical radiograph with occlusal radiograph. The advantage of taking occlusal radiograph, it will show you any movement of the tooth within the alveolar bone, and sometimes it could show you if there is a fracture of the root. Pre-apical radiograph is the standard, and we usually take more than one to see the relationship of the tooth within the socket and in adjacent to the other teeth. Also, we use radiographic examination to examine the soft tissue and to see if there is any hard tissue within the lip. So we remove it and we take another radiograph. We make sure that there is nothing within the soft tissue before we do the suture. Enamel fracture, from its name, it's confined to the enamel. Rarely there is some tenderness or mobility. The pulp will respond normally, and if needed, we can do some smoothing to the enamel, or we add a small restoration. If there is a significant loss of the enamel, like 1 to 2 millimeter, without pulp exposure, then you could treat it as a simple class 3, and sometimes the tooth will be tender. When the segment of the fractured tooth is larger, that means the amount of force that the tooth was exposed to is greater. So the pulp consequently will be affected more. When the pulp gets exposed after a trauma, the status of the pulp determine the intervention to the pulp, and the care of the crown is the standard care. Either you do restoration or crown, depending on the need of the patient and the development of the tooth. If the tooth is young, it's a permanent tooth and it's young, that means the apex is open. We could do direct pulp capping if the tooth is vital, because our objective is to maintain the pulp of vital to complete the tooth development. The recommended material currently is MTA. Some practices they use calcium hydroxide. The technique is very simple. You make sure that the site is clean. The exposure of the bulb has a clean and clear margin, and then you apply the material over it. If there is any excessive bleeding, we can usually control it by pressure, or sometimes we apply hemostatic agent. If the exposure has been for weeks, and when you look at the site of the bulb, you cannot see any tissue, we cannot do direct bulb capping. One approach is to do some partial pulpotomy technique. This is usually when you have some inflammation. The bulb is vital, but it's a little bit inflamed. You can see some granulative tissue. So you can remove part of it, control the bleeding, apply the material. This is all the bulb is vital. Now, if the bulb tissue is not vital, because the trauma happened long time ago before the patient present to your clinic, then in that case you're gonna open the root canal system completely, make sure it's clean, and then you're gonna apply the material to the root end. Now there are new practice. They say you have to do some pulp revascularization, which means regenerating of the pulp tissue. We have one goal. We want the radicular tintin at the apical third to continue growing and to close the apex. The recommended material is a triple antibiotic paste containing ciprofloxacin, metronidazole, and minocycline. And the technique is very simple. After you clean, if there is no bleeding, you're gonna generate bleeding by using a file in the apical third of the root. Once there is a bleeding, you're gonna apply the triple antibiotic in the coronal half of the root, not in the apex, coronal half. This is some images of how we do several vital pulp therapy depending on the time of the presentation of the patient after the trauma, and it depends on the development stage of the root. One of the significant trauma that take place in the teeth is root fracture. When root fracture happen, there are some clinical signs that could help you make a suitable decision. Is the coronal segment mobile or not? If the coronal segment is fixed, then usually you have a really good prognosis. Is there a bleeding from the gingival sulcus? Doing a bulb test, some practitioners do it, but usually, if you want to do it, do it. Now the recommended radiograph is to take a pre-apical radiograph and 2 additional radiographs by changing the horizontal and vertical angulation. And sometimes there is no displacement. If there is no displacement, you cannot see the fracture. The follow-up will extend up to 5 years. The favorable outcome, you have a positive pulp response. You don't see any pre-apical changes. This is the favorable. The unfavorable outcome, the tooth become painful, or there is some pre-apical radiolucency, or if the pulp test is applicable, then the pulp will be necrotic. The second significant trauma, which is the extrusive luxation, that means the tooth has been displaced from its socket in an axial direction. Clinically, it will appear a longer tooth, sometimes with increased mobility. Response to the pulp test will be variable. If you take a radiograph, you're going to see that the width of the periodontal ligament space has been increased in this tooth compared to the other teeth. Occlusal radiograph, if it's anterior, will show this space along the root. Usually the recommended treatment is to reposition the tooth by gently pushing it back and we do splinting, flexible splint for 2 weeks. And of course, you need to monitor the tooth as it's written here, 2 weeks, 4 weeks, up to 5 years. The unfavorable outcome: necrosis, periapical radiolucency, some external root resorption, which is treated as any endodontic disease. Lateral luxation is it has a displacement also of the bone. This is the difference between lateral luxation and subluxation. So this is really a major trauma. And the clinical finding, you will see that actually the tooth is out from the alignment of the teeth. It will be either buccal or lingual. It could be really hardly fixed at this position. When you take a radiograph, you will see that this tooth is not within the level of the other teeth. Now the treatment, you have to reposition the tooth digitally. Digitally meaning using your digits, which is the fingers. And then you're going to stabilize it up to 4 weeks. You're going to monitor the pulp condition. Teeth with incomplete root formation, they have a favorable chances for healing, but they could also get necrotic. In this case, we also have to do for it endodontic treatment. Endodontic treatment is really dictated by the status of the apex. If you have an open apex, you're gonna treat it as in the apexification. Doing revascularization for teeth after lateral luxation is not, I'm not familiar with it honestly. So you're gonna treat it as apexification. If the apex is closed, then you'll just do standard endo treatment. And also the follow-up go to up 5 years. And the favorable and unfavorable outcome is the same. Then we have intrusive luxation. That means the tooth has been driven inside the socket, so it will appear shorter. And there in the radiograph there will be no periodontal ligament space. So the treatment, if it is incomplete root, that means the apex is open, usually it re-erupt within 4 weeks. If the tooth is mature, you're gonna give it a chance to re-erupt within 2 months, or you could just simply reposition it surgically and splint it for 4 weeks. It depends on your clinical judgment. And then also here in the table they have give us a guideline, which is the amount of intrusion. If it's less than 3 millimeter, then we allow it to re-erupt. If it is more than 3 millimeters, so it is recommended to reposition it surgically or orthodontically. So as the intrusion level is more like beyond 7 millimeters, definitely you have to do it surgically. The same about favorable and unfavorable outcome. External root resorption, it's an event that we don't have like for it directly an intervention. The only intervention available to us is just to remove the pulp tissue and put root canal material. Okay, the major dental trauma is avulsion. Avulsion means the tooth is out of the socket. And it's very important that we locate the tooth and we place it inside the socket as soon as possible after we follow the recommended steps. So avulsion account for less than 3% of all dental injury, and as I said, it is really depend on the action taken in the accident site within 1 hour. So if the site is clean and the tooth is available, you're gonna wash it with the saline and then you re-implant it in its place. Just replant it. If you don't know how, you could just transport the tooth in a milk or in a storage medium and go to the nearest dental office. And the Society for Dental Trauma has a guideline poster that is also available in Arabic. You can put it in your clinic and share it with your patient. Now, the treatment guideline for the pulp after a vulge accident, as I said, it determined on the time between the trauma and the replantation. If the time is less than 60 minutes and it's actually less than 15 minutes, we have the most favorable prognosis. If it's less than 60 minutes, still it's favorable, but the consequence of root resorption or necrosis is higher. If it's more than 60 minutes, so it has the poorest prognosis. Either way, replanting the tooth is the correct step to do. So the headlines, you're gonna clean it. If there is some laceration, you're gonna do some suturing. The splint is a soft splint, usually 0.4 millimeter if it's a stainless steel wire, and if it's a nylon, it will be 0.25. And we prescribe antibiotics, even though it's controversial, just to cover any effect of the soft tissue. And if the playing area is dirty, then you might need a tetanus post. And we also give the patient post-operative anesthesia. The alveolar socket is an important aspect in the avulsion trauma. You want to make sure that it's clean, not dirty. And if there is a coagulum that prevents replantation of the tooth, it has to be removed by gentle irrigation using saline. Now, doing pulpectomy and root canal treatment is more probable. The probability is higher if the tooth has been replanted after 1 hour. But any tooth could become necrotic, and then you have to do root canal treatment, and this appears at the follow-up visit. Now, the treatment guidelines for avulsed permanent teeth with open apex is a bit different because we want the root to complete its development. That's why revascularization is indicated if the time is more than 15 minutes and less than 1 hour. After 1 hour, they said that you have to do root canal treatment. Some practitioners, honestly, they also try revascularization. So, in all trauma, if you're gonna intervene, you have to give the patient local anesthesia. It will really ease the patient and they will be cooperative. There are some recommendation not to use vasoconstrictor, even though there is no clear evidence that vasoconstrictor will affect the healing of the tissue. If the area is edematous or the laceration is huge and you cannot do regular infiltration, you can do some block anesthesia at the infraorbital foramen or inferior alveolar nerve block. As I said, antibiotics usually prescribed, and it is systematic. Applying topical antibiotic is controversial, and until now we don't have like a strong evidence. Topical, that's mean over the root surface or inside the alveolar socket. Now the follow-up, as it shows in the previous slide, 2 weeks, 4 weeks, up to 5 years. The justification of splinting, we want the tooth to be in its right position, and we want the patient to be comfortable during function, and as I said, it's flexible and up to 2 weeks. Now the patient instructions are to avoid contact sport, take soft diet for 2 weeks, use a soft brush, and they have to use chlorhexidine mouthwash twice a day for 2 weeks. The core outcome, as it was presented by the Traumatic Dental Injury Society, we have generic outcome, which are periodontal healing, pulp space healing for open apex teeth. Patient can have pain, discoloration, patient could lose the tooth. The quality of life in smiling or chewing could be affected. And some patients, they get some anxiety, and there will be additional visit to the clinic. And then they have also injury specific outcome, which are the tooth become short, which is called infra-occlusion. Now we're going to take a few slides about the management of trauma in primary dentition. If there is a crown fracture with pulp exposure, we can either do pulpotomy or extraction, depend on the patient age and cooperation. If there is crown root fracture, extraction. If there is root fracture, usually we don't do any treatment. We could remove the coronal segment and leave the apical part. It depends on the amount of mobility within the tooth. If there is some kind of luxation, lateral or extrusive, we don't do any treatment. Or sometimes we can do extraction if it's gonna affect the site of eruption of the permanent tooth. If it is intrusive, we could do extraction, or we can leave it to re-erupt. And if there is avulsion, we usually don't do anything. We don't replant it has been out of the socket. Thank you, and if you have any question, you can send me an email.